Welcome to Pediatric Case Review, Musculoskeletal Series. Today's lecture is a comprehensive case-based review of avascular necrosis of the femoral head in children, covering both idiopathic leg calf-Pertus disease and secondary causes. We will work through 14 clinical cases exploring pathophysiology, clinical presentation, examination findings, radiological staging, the Herring lateral pillar classification, conservative and surgical management, complications, prognostic factors, and secondary avascular necrosis. Let us begin. Case 1. A 6-year-old boy presents with a 3-week history of painless limp. Parents deny any trauma. On examination, there is mild restriction of internal rotation of the right hip. Pelvic X-ray shows mild flattening of the right femoral head. Which of the following best describes the primary pathophysiological mechanism in this condition? Option A. Inflammatory synovitis destroying articular cartilage. Option B. Disruption of blood supply to the femoral epiphysis causing ischemic necrosis. Option C. Traumatic fracture of the femoral neck with avascular sequelae. Option D. Autoimmune-mediated osteoclastic resorption of the epiphysis. The correct answer is option B. Disruption of blood supply to the femoral epiphysis causing ischemic necrosis. Avascular necrosis of the femoral head occurs when the lateral epiphyseal arteries, which are branches of the medial circumflex femoral artery, are interrupted. This leads to ischemia of the ossific nucleus followed by a subchondral fracture seen as the crescent sign. Revascularization then triggers fragmentation and resorption of necrotic bone, followed by reossification and remodeling. A critical point is that the articular cartilage survives throughout this process because it receives nutrition directly from synovial fluid rather than from blood vessels. Inflammation plays no primary role in leg calf-Pertus disease. Case 2. A 5-year-old male is brought by his parents due to an intermittent limp for 6 weeks. The limp worsens with activity and partially improves with rest. There is no fever, weight loss, or morning stiffness. He is otherwise healthy. On review of systems, parents note mild groin and medial thigh pain occasionally radiating to the knee. Which of the following best describes the typical clinical presentation of this condition? Option A. Bilateral hip involvement with symmetrical limping. Option B. Acute onset severe hip pain following minor trauma. Option C. Insidious onset painless or mildly painful limp in a boy aged 4 to 8 years. Option D. Morning stiffness lasting more than 1 hour with joint swelling. The correct answer is option C. Insidious onset painless or mildly painful limp in a boy aged 4 to 8 years. Leg calf-Pertus disease has a peak incidence between 4 and 8 years of age with a male-to-female ratio of 4 to 1. The onset is always insidious with an activity-related antalgic limp that improves with rest. Pain is mild and felt in the groin, medial thigh, or referred to the knee. Systemic symptoms including fever and weight loss are absent, which distinguishes this condition from septic arthritis and juvenile idiopathic arthritis. Bilateral involvement occurs in 10 to 15% of cases, but is almost always asynchronous. Affected children often have short stature and delayed bone age. Case 3. A 7-year-old boy with a 4-week history of right hip pain and limp is assessed in clinic. Vitals are normal. On physical examination, the physician notes an antalgic gait favoring the right side. Which combination of examination findings is most consistent with leg calf-Pertus disease at this stage? Option A. Loss of internal rotation and abduction with hip held in flexion and external rotation at rest. Option B. Positive flexion abduction external rotation test, normal range of motion, no muscle wasting. Option C. Trendelenburg gait, full painless range of motion and positive Thomas test. Option D. Crepitus, varus deformity, and leg length discrepancy as the only findings. The correct answer is option A. Loss of internal rotation and abduction with the hip held in flexion and external rotation at rest. The earliest and most reliable physical sign of leg calf-Pertus disease is loss of internal rotation, which reflects synovial irritation and capsular tightening around the hip. Abduction is also progressively restricted. The hip assumes a position of mild flexion and external rotation at rest to minimize intra-articular pressure. An antalgic gait with a shortened stance phase is characteristic. Trendelenburg gait and quadriceps or gluteal muscle wasting occur in chronic or neglected cases. The Thomas test may be positive when a flexion contracture develops. Stiffness rather than pain is the hallmark of the condition on examination. Case 4. A 6-year-old boy presents with a 5-week limp and mild groin pain. Anteroposterior and frog leg lateral pelvic X-rays are obtained. The radiologist notes a crescent-shaped subchondral lucency along the superior aspect of the right femoral epiphysis without significant flattening. The femoral head appears smaller than the left side. What radiological stage does this X-ray finding represent in the Waldenström classification of leg-calf-Pertus disease? Option A, Stage 4, healing and reossification stage. Option B, Stage 3, reossification stage. Option C, Stage 2, fragmentation stage with mixed lucency and sclerosis. Option D, Stage 1, initial ischemic stage with increased density and crescent sign. The correct answer is Option D, Stage 1, the initial ischemic stage. The Waldenström classification describes 4 radiological stages of leg-calf-Pertus disease. Stage 1 is the initial ischemic stage characterized by increased epiphyseal density, a smaller epiphysis, subchondral fracture visible as the crescent sign, and joint space widening. The crescent sign is pathognomonic of Stage 1 and represents a subchondral fracture line. Stage 2 is fragmentation, showing mixed lucency and sclerosis with epiphyseal breakdown. Stage 3 is reossification with new bone formation and gradual reconstitution. Stage 4 is healing with remodeling that may result in coxa magna or coxa plana. An important teaching point is that Stage 1 may be entirely X-ray negative, requiring magnetic resonance imaging for early diagnosis. Case 5. An 8-year-old girl presents with a 3-week right hip limp. Plain X-rays show only subtle joint space widening with no bony changes. Her erythrocyte sedimentation rate is 12 millimeters per hour and white blood cell count is normal. The orthopedic surgeon suspects early avascular necrosis of the femoral head. Which magnetic resonance imaging finding would be most diagnostic of early avascular necrosis of the femoral head in this child? Option A, high T2 signal throughout the femoral epiphysis indicating bone marrow edema. Option B, low T1 signal in the anterosuperior femoral epiphysis indicating ischemia and necrosis. Option C, gadolinium enhancement of the entire femoral head. Option D, cortical irregularity of the femoral neck on T2 weighted sequences. The correct answer is Option B, low T1 signal in the anterosuperior femoral epiphysis indicating ischemia and necrosis. Magnetic resonance imaging is the gold standard for early diagnosis of avascular necrosis of the femoral head and can detect changes before any abnormality appears on plain radiographs. The hallmark finding is T1 hypointensity in the anterosuperior femoral epiphysis, which represents ischemic and necrotic bone marrow. T2 hyperintensity in the surrounding tissue reflects bone marrow edema and reactive change. Gadolinium perfusion magnetic resonance imaging adds further value by showing a non-enhancing epiphysis, confirming absent blood flow. A bone skin showing decreased uptake in the affected epiphysis is another early investigation, but magnetic resonance imaging has superior specificity and anatomical detail. Case 6. A 7-year-old male with confirmed leg-calf-Pertus disease is in the fragmentation stage on X-ray. The orthopedic surgeon uses the Herring lateral pillar classification to guide treatment decisions. On anteroposterior X-ray, the lateral column of the femoral epiphysis retains 50% of its original height with some lucency, but visible bone density. Which Herring group does this represent? Option A, Group A, lateral pillar fully maintained with no lucency. Option B, Group C, lateral pillar height less than 50% retained. Option C, Group B, lateral pillar height 50% or more retained with some lucency. Option D, Group B/C border, lateral pillar exactly 50% with thin ossification. The correct answer is Option C, Herring Group B. The Herring lateral pillar classification is applied during the fragmentation stage and divides the femoral epiphysis into 3 columns: medial, central, and lateral. The classification is based entirely on the height of the lateral column. Group A means the lateral pillar is fully maintained with no lucency and carries the best prognosis. Group B means the lateral pillar retains 50% or more of its original height with some lucency, representing intermediate risk. Group C means less than 50% of lateral pillar height is retained and carries the worst prognosis. The Group B/C border is a high-risk subgroup requiring aggressive management. This classification directly determines whether conservative or surgical containment is indicated. Case 7. A 5-year-old boy is diagnosed with leg-calf-Pertus disease of the right hip, Herring Group B, age at onset 5 years. He has mild loss of abduction and internal rotation, but retains more than 50% range of motion. X-ray shows early fragmentation without significant lateral pillar collapse. Which of the following is the most appropriate initial management strategy? Option A, activity restriction, physical therapy for range of motion, and observation with serial imaging every 4 to 6 months. Option B, immediate total hip arthroplasty to prevent further collapse. Option C, immobilization in a hip spica cast for 12 months. Option D, oral corticosteroid therapy to reduce synovitis and protect the femoral head. The correct answer is option A, activity restriction, physical therapy for range of motion, and observation with serial imaging every 4 to 6 months. In a child under 6 years of age with Herring Group A or B disease and preserved range of motion, conservative management is the recommended initial approach. The goals of conservative treatment are to maintain range of motion, especially abduction, prevent femoral head extrusion from the acetabulum, control pain with nonsteroidal anti-inflammatory drugs, and monitor disease progression with serial X-rays every 4 to 6 months. Children under 6 years with good range of motion have an excellent prognosis with observation alone because of the significant remodeling potential of young bone. Total hip arthroplasty, spica casting, and corticosteroids are not indicated at this stage. Case 8. A 9-year-old girl presents with Legg-Calvé-Perthes disease in the fragmentation stage. Herring classification reveals Group C involvement. She has limited abduction to 20 degrees and hip radiograph shows lateral epiphyseal extrusion of more than 20%. Despite 4 months of conservative management, she has not improved. Which surgical procedure is most commonly performed to achieve femoral head containment in this scenario? Option A, shelf acetabuloplasty as the sole procedure without femoral osteotomy. Option B, total hip replacement to restore hip joint anatomy. Option C, cord decompression of the femoral neck to restore vascularity. Option D, proximal femoral varus derotation osteotomy to redirect the femoral head into the acetabulum. The correct answer is option D, proximal femoral varus derotation osteotomy. This procedure is the most commonly performed surgical containment operation for Legg-Calvé-Perthes disease. It corrects the neck shaft angle and redirects the femoral head centrally into the acetabulum, thereby maximizing coverage and preventing further lateral extrusion. It is indicated in children aged 8 years or older with Herring Group B/C or Group C disease and lateral extrusion above 20% who have failed conservative management. Containment surgery is best performed during the fragmentation stage when the femoral head is most plastic and remodeling potential is highest. Core decompression is used in secondary avascular necrosis, such as sickle cell disease, not in standard Legg-Calvé-Perthes management. Total hip replacement is reserved for end-stage disease in adults. Case 9. A 14-year-old male is reviewed in the orthopedic clinic. He was diagnosed with Legg-Calvé-Perthes disease at age 6, Herring Group C. He did not receive surgical treatment. Current anteroposterior pelvis X-ray shows a mushroom-shaped, flattened right femoral head that no longer fits the acetabulum. He reports worsening right groin pain with activity and decreased walking tolerance. What is the most likely long-term complication present in this patient? Option A, avascular necrosis of the contralateral hip. Option B, stress fracture of the femoral neck due to osteopenia. Option C, coxa magna with incongruence leading to early-onset secondary osteoarthritis. Option D, septic arthritis superimposed on necrotic femoral head. The correct answer is option C, coxa magna with incongruence leading to early-onset secondary osteoarthritis. Coxa magna refers to enlargement and flattening of the femoral head that develops during the healing and remodeling stage of Legg-Calvé-Perthes disease. When the enlarged head no longer fits congruently within the acetabulum, joint incongruence develops, leading to uneven load distribution and progressive cartilage wear. This results in early-onset osteoarthritis, often presenting in the 2nd or 3rd decade of life. Coxa plana describes a severely flattened disc-shaped femoral head associated with severe osteoarthritis. Hinge abduction occurs when the irregular femoral head levers against the acetabular rim during motion, causing painful limited abduction. Poor prognosis predictors include Herring Group C, age above 8 years, and lateral extrusion above 20%. Case 10. During grand rounds, a pediatric resident presents 4 cases of avascular necrosis of the femoral head in children. One case involves a 12-year-old with sickle cell disease and bilateral hip pain. Another is an 8-year-old on long-term corticosteroids for nephrotic syndrome. A third is a 3-year-old following treatment for developmental dysplasia of the hip. The fourth is a 6-year-old with idiopathic Legg-Calvé-Perthes disease. Which of the following underlying mechanisms is shared between corticosteroid-induced avascular necrosis and sickle cell-related avascular necrosis? Option A, autoimmune destruction of the epiphyseal growth plate. Option B, vascular occlusion causing ischemia of the femoral epiphysis through different mechanisms. Option C, inflammatory cytokine-mediated osteoclast activation. Option D, direct toxic effect of medications on chondrocyte. The correct answer is option B, vascular occlusion causing ischemia of the femoral epiphysis through different mechanisms. Both conditions ultimately cause ischemic necrosis of the femoral head through vascular occlusion, but the mechanisms are distinct. In sickle cell disease, sickling of red blood cells occludes the sinusoidal vessels within bone, causing direct vascular blockage and infarction. In corticosteroid-induced avascular necrosis, fat cells in the bone marrow expand due to steroid-driven lipid accumulation and compress the intraosseous vessels, and fat emboli may also cause thrombosis of epiphyseal arteries. Other secondary causes include coagulopathies such as protein C and protein S deficiency, thalassemia, Gaucher disease, radiation therapy, septic arthritis, trauma, and iatrogenic injury from treatment of developmental dysplasia of the hip. Case 11. A 4-year-old girl presents with 2 weeks of left hip pain and limp. Temperature is 38.7 degrees Celsius. White blood cell count is 16,000 per cubic millimeter. Erythrocyte sedimentation rate is 68 millimeters per hour, and C-reactive protein is 42 milligrams per liter. Hip ultrasound shows joint effusion. Coker criteria are assessed, which diagnosis must be urgently excluded before attributing her symptoms to early leg calf Pertus disease. Option A, septic arthritis requiring emergency surgical washout. Option B, transient synovitis of the hip. Option C, juvenile idiopathic arthritis with acute flare. Option D, reactive arthritis following recent upper respiratory infection. The correct answer is option A, septic arthritis requiring emergency surgical washout. This child meets 3 of the 4 Coker criteria. Fever above 38.5 degrees Celsius, white blood cell count above 12,000, and erythrocyte sedimentation rate above 40 millimeters per hour. The 4th criterion, non-weight bearing, is borderline. 3 Coker criteria predict a 73% probability of septic arthritis, and 4 criteria predict 93%, mandating emergency surgical drainage. Leg calf Pertus disease characteristically presents with no fever, normal inflammatory markers, and an insidious painless limp. Transient synovitis is afebrile with mildly elevated or normal inflammatory markers and is self-limiting. Juvenile idiopathic arthritis causes morning stiffness and polyarticular involvement. Failing to exclude septic arthritis can result in cartilage destruction and permanent joint damage. Case 12. 2 patients are diagnosed with leg calf Pertus disease in the same clinic. Patient A is a 5-year-old boy with Herring group A, early fragmentation, and full abduction to 45 degrees. Patient B is a 10-year-old girl with Herring group C, advanced fragmentation, abduction limited to 15 degrees, and lateral epiphyseal extrusion on X-ray. Which factor combination in patient B most strongly predicts a poor outcome? Option A, female sex alone is the primary poor prognostic indicator. Option B, earlier disease stage and presence of metaphyseal cysts. Option C, body mass index and family history of hip osteoarthritis. Option D, older age at onset above 8 years, Herring group C, and limited abduction. The correct answer is option D, older age at onset above 8 years, Herring group C, and limited abduction below 15 degrees. The 3 strongest validated predictors of poor outcome in leg calf Pertus disease are age above 8 years at diagnosis, Herring group C lateral pillar classification, and abduction range of motion below 15 degrees. Additional poor prognostic factors include lateral epiphyseal extrusion above 20%, female sex, and Stulberg class 4 or 5 at skeletal maturity. Female patients with the same Herring grade consistently have worse outcomes than male patients. In contrast, patient A has excellent prognostic features: young age under 6 years, Herring group A, and preserved abduction above 45 degrees, predicting Stulberg class 1 or 2 and no significant osteoarthritis risk. Case 13. A 10-year-old male with known homozygous sickle cell disease presents with acute onset right hip pain during a pain crisis. Examination reveals restricted hip motion and tenderness. After the acute episode resolves, persistent hip stiffness and pain remain. Anteroposterior X-ray of the pelvis shows a sclerotic right femoral head with subtle subchondral flattening. Magnetic resonance imaging demonstrates a large anterior superior wedge of T1 hypointense signal in the right femoral epiphysis. Which of the following distinguishes secondary avascular necrosis in sickle cell disease from idiopathic leg calf Pertus disease? Option A. Secondary avascular necrosis in sickle cell disease has better remodeling potential than Legg-Calvé-Perthes disease. Option B. Legg-Calvé-Perthes disease more commonly affects females than sickle cell-related avascular necrosis. Option C. Sickle cell-related avascular necrosis typically presents older, is bilateral, and has less remodeling potential. Option D. Bone marrow magnetic resonance imaging changes are absent in sickle cell-related avascular necrosis. The correct answer is option C. Sickle cell-related avascular necrosis typically presents in older children aged 8 to 10 years or above, is bilateral in 30 to 50% of cases, and has less remodeling potential than idiopathic Legg-Calvé-Perthes disease. In contrast, Legg-Calvé-Perthes disease affects younger children aged 4 to 8 years, is bilateral in only 10 to 15%, and has good remodeling potential due to younger bone age. Legg-Calvé-Perthes disease has a 4-to-1 male predominance, while sickle cell-related avascular necrosis affects males and females equally. On magnetic resonance imaging, sickle cell-related avascular necrosis shows a large anterior superior wedge of T1 hypointense signal and marrow infarction, while Legg-Calvé-Perthes shows subchondral T1 low signal. Treatment of sickle cell-related avascular necrosis includes cord decompression in early cases plus containment, and prognosis is generally worse than idiopathic disease. Thank you for watching Pediatric Case Review. I want to invite you to join our exclusive Patreon community called Pediatric Case Review. In this community, all videos are carefully organized by medical system, so you can find and access every lecture in one convenient place without searching through different platforms. All presentation slides used in the videos are also available as downloadable photo files, so you can read through the cases and practice all questions at your own pace. We also provide case-based question banks to reinforce your pediatric knowledge. If you would like to join, simply comment below on this post, and we will message you directly with all the subscription details. Case 14. An 8-year-old boy is referred for a 6-week history of right hip pain and limp. X-ray confirms Legg-Calvé-Perthes disease in the fragmentation stage with Herring group B/C lateral pillar classification. Abduction is limited to 25 degrees bilaterally. Magnetic resonance imaging shows anterosuperior epiphyseal necrosis with more than 20% lateral extrusion. He has failed 3 months of activity modification and physical therapy. His parents ask about surgical options and expected outcomes. Which of the following management decisions is most appropriate at this time? Option A. Continue conservative management for another 12 months before considering surgery. Option B. Perform proximal femoral varus derotation osteotomy to achieve containment during the active fragmentation stage. Option C. Proceed with total hip arthroplasty due to advanced disease. Option D. Prescribe bisphosphonate therapy to prevent further femoral head collapse. The correct answer is option B. Perform proximal femoral varus derotation osteotomy to achieve containment during the active fragmentation stage. This boy has multiple high-risk features. Age 8 years, Herring group B/C classification, limited abduction, more than 20% lateral extrusion, and failure of conservative management. The optimal timing for containment surgery is the fragmentation stage when the femoral head is most biologically plastic and responsive to redirectional loading. Total hip arthroplasty is only appropriate for end-stage disease in adults, not in a child. Bisphosphonates are not standard therapy in Legg-Calvé-Perthes management. Continuing conservative treatment after documented failure and progressive extrusion would risk irreversible femoral head deformity. Key takeaways from today's lecture. Avascular necrosis equals vascular disruption leading to ischemic necrosis of the femoral epiphysis. Legg-Calvé-Perthes affects boys age 4 to 8 years with insidious limp and restricted internal rotation. Magnetic resonance imaging allows earliest diagnosis. The Herring classification guides treatment. An age above 8+ Herring group C equals surgical containment. Follow Pediatric Case Review for more lectures and comment below if you have any questions.